Hey, Kel, can you hear me?
Yes, I can.
All right, cool.
Cool.
Thank you.
Anytime.
All right, guys, it's 1 o'clock. Let's get through this. Welcome to this study group. Um, I know I sent out an email last week about a LSRT program that I've put together. Um, it's actually going to be found on the Sterling intranet, and it's all going to be in one place where you can go and look at all these modules and go through them at your own pace. I think that we're going to continue to have just a study session each week, where you guys can hop on and ask questions that you have, or we can discuss different things that maybe you're not real clear about. To the end goal of getting your LSRT license. That's what this program is geared towards. And I hope that you guys will take advantage of that. Having it all in one place is going to be nice. And, I'm there for you. So, like I said, I think we'll continue to have a study group at least once a week where we can hop on and discuss things. And get you guys caught up to where you need to be in order to take the test. Anyway, I appreciate you guys being here today, and let's get started here. We are just going to go through a couple positioning things today. It's just the didactic part of it, so it's the book part of it. It's not real interesting, but it's stuff that you need to know for the test. So that is what we're going to do. Okay, so let's get started. So let's see, can you guys see that okay? There we go. Okay, all right, LSRT, limited scope radiologic technologist, study group number 15. We've gone through 15 of these, which is pretty cool. But we've discussed a lot of different things that you need to know for this exam, and I hope that you guys continue to study, and we will have another study group next week, and then hopefully by that time we'll be able to get this group in order and get things rolling that way. Anyway, so here we go. So we're going to talk about positioning of the chest, abdomen, spine, and skull today. Just bear with me. We're just going to run through these real quick. This is stuff that, like I say, you need to know, not only for positioning the patient, but for test purposes. You need to know your SIDs, your 40 inches, 72 inches. Most of them are 40, which helps. But we're going to talk about a chest 2 view, which we do a lot of. And the SID is 72 inches. And the reason we do that is, or take our picture at 72 inches, is to reduce the magnification of the heart, for the fact that there's distance between the image receptor and the heart. We need to combat that by bringing our tube further back, which is going to reduce the magnification of the heart and give us a true value as far as the heart size go, which is important. So always remember to shoot our chest at 72 inches. Okay. So there's no tube angle, and the central ray is going to be right at T7, okay, or right at the lower border of the scapula. Okay, that's where you're going to put your crosshair. Okay, you want to make sure that you include both sides, both skin margins, both lateral skin margins. We also want to include 1.5 to 2 inches above the shoulder. And we also want to include the costophrenic angles, or we need to include the entire lung field. Okay, so collimation is important. Most of the time, you're going to be opened up pretty good collimation wise, unless you're shooting a child, in which case you do want to collimate to the size of the lungs. We just need to make sure that we get the entire lung field in both of our pictures, both the lateral and the PA. Okay. Practical points, the phase of respiration is very important for a chest x-ray. The proper technique is have the patient take in a deep breath, blow that breath out, and take another deep breath in. It's called second inspiration, and you need to know that for test purposes. And the reason we do that is, the experts say that on your second inspiration, you're actually bringing more air into the lungs. And for these pictures, we want those lungs to be inflated as much as we possibly can. So when we do those, take chest x-rays, remember it's on second inspiration, okay? A poor inspiratory PA radiograph can mimic pathology. So it's important that we get our patients to hold a good deep breath. And sometimes with small children, it's very difficult to do. And in that case, you just do the best that you can. You're not going to have a 3-year-old take a breath in, blow it out, and take another deep breath in. You're going to try and time your x-ray to their inspiration. You'll get really good at watching a child breathe and know when they're in their inspiration phase, and you'll take that picture. It's such a quick exposure that you're usually able to get that on inspiration. It's something you need to watch for and look for. But chest x-rays are very important. We can see a lot of different things with a chest x-ray as far as what's going on with the patient. And just remember they're 72 inches and on second inspiration. Make sure you get the entire lung filled. Okay, and here we've got nice pictures down there showing you what that should look like. You'll note on the PA right here, he's got his shoulders rolled forward. And the reason we do that is to get the scapulas out of the lung field, okay, less for us to look through. So make sure on the lateral that the arms are up. Most of our machines don't have this fancy stuff that you can hold on to, but it works just as well to have the patient raise their arms and put their hands on their head, okay? Just always remember to get their chest or their left lateral side as close to the image receptor as you possibly can, okay? All right, abdomen. We do a lot of abdomens too. So there's 2 different abdomens that we can do. An AP supine, which is a KUB, and KUB stands for kidney, ureter, bladder, okay, and an upright. Upright, I think, are more useful. You can see more air fluid levels within the bowels. They just, to me, have more information, and I try to do those more often than not. So central ray, no tube angulation, you don't have to worry about that. For KUB, the central ray is the level of the iliac crest. Okay, you're laying down on the table, and you're going to put your cross right at the iliac crest and the mid-sagittal plane. Okay, for an upright, it's 2 inches above the iliac crest. Let me kind of explain this a little bit. Why there's a difference there. So for an upright abdomen, we need to be able to see the diaphragm, okay, the entire diaphragm. And that's the reason that we put our central ray a little bit higher on an upright image, whereas lower with the supine or the KUB, it's right at the iliac crest because we want to be able to see the pubic symphysis. So in a perfect world, we should see the diaphragm and the pubic symphysis. Sometimes that takes 2 pictures. So if you do an upright and your diaphragms are nice and pretty, but you can't see the pubic symphysis, it's okay to take one a little bit lower so that the doctor can look at the bladder, and vice versa with a KUB. If you shoot your KUB and you've got your pubic symphysis, but you can't see your diaphragms, it's okay to do what they call a T-top. Which is just a higher image to see the diaphragms. Okay, so keep that in mind. For me, I think that we always ought to see both diaphragm and pubic symphysis. So sometimes it does take 2 pictures unless you're shooting a child or a small adult. So technical factors, you shoot our KUBs are upright at 70 kVp. Mass between 10 and 30 depending on the size of the patient. You can go all the way up to 200 or 300 mass depending on the size. If you've got a big person with a big barrel chest and belly, you're going to have to hit them a little bit harder. Okay, but normal size people, 70 kVp at 10 to 30 mass. Let's see, for larger patients, it may be necessary to perform 2 x-rays using landscape orientation of the detector, include the entire abdomen. We've already talked about that, about including from the diaphragms all the way down to the symphysis pubis. So exposure will need to be adjusted according to the image system, CR, DR, and patient size. Where possible, mass should be manipulated to ensure adequate image density and appropriate image contrast. Okay, and as we go along, you're going to get much better at that. As far as you take your first picture and it's grainy and really light, at that point that you're going to have to at least double your mass, probably quadruple your mass, in order to make that picture look okay. Okay, and like I say, in one of these next study groups, we're going to talk a lot about techniques. So C-spine, one of my favorite things to do, other than the pictures I've got down here for the C-spine are kind of creepy, and I apologize for that. But I thought that they showed really well what it looks like, or what it should look like. Okay, so the projections, we're going to do a lateral, an AP, and a odontoid. And if we don't get the C7 T1 joint space, we need to do a swimmer's view. Okay, so you're always going to do a swimmer's view with the thoracic spine. With the C-spine, it's optional whether you're able to see C7 T1 on your lateral C-spine. Okay, now this is something that you do need to know. So the SID for a lateral C-spine is actually 72 inches. And the reason we do that, again, is for magnification, because you've got the patient's shoulder against the image receptor and their spine's coming up right here. So you have this much distance between the spine and the image receptor. And again, we're going to combat that by bringing our tube back to 72 inches to give us a more manageable look at the C-spine and not magnified like it would be. But so I always shoot my lateral first, just because it is at 72 inches, and then I can bring my tube into 40 inches for the last 2 or 3 pictures. So center ray for the AP, you're actually going to angle your tube 15 degrees cephalic, or towards the head, and your center ray is going to be right at C4, or right below the Adam's apple, or the hyoid bone. Okay, so your center ray for the odontoid picture, the bottom right one, is right into the open mouth. Okay, collimation for the AP, we need to include both sides of the neck. Okay, superior to include C2 and inferior to include T2. So when we shoot the AP, we're not going to be able to see C1 and most of the time C2. We're going to see C3 through T2. Okay, and that's why we do the angle up, so we can see up in here a little bit further through the jawline. So technical factors, 70 kVp at 10 to 12, 15 mass, right around that stage, depending on the size of the patient again. Now, when you're shooting your lateral, always make sure you relax that patient's shoulders so we can see C7 T1. Like I say, it's important to relax the shoulders. When we do the odontoid, it's also important that we get our mastoid tip and our lower jaw lined up with each other, so the head is straight. Okay, we don't want any rotation either way, because the dens, the part of C2 that comes up through C1, we want to be able to see that entirely. So we don't want to superimpose that with the occipital bone or the upper teeth, and it's kind of a fine line right there, and you'll get to the point where you'll get it every time. So these pictures are taken on full expiration, so take a breath in, blow it all the way out, and hold it out. Okay, it helps relax those shoulders down a little bit, the reason we do that. Okay, but yeah, C-spines are cool. Just, for test purposes, realize that the lateral is done at 72 inches. The odontoid AP and swimmers, if necessary, are done at 40 inches. Okay. Remember your central raise at C4, and you've got a 15-degree cephalic angle for your AP. Okay. Thoracic spine. This was one of my worst things to do when I was in school. I just didn't like thoracic spines. Now they're no big deal. So projections, we're going to do an AP and a lateral and a swimmer's lateral. Okay, 0-degree tube angle, and the central ray is at level T7. Okay, collimation wise, we want to be able to see both sides of the spine, right? We want to be able to see the C7 T1 junction, and we also want to see the T12 L1 junction, meaning we want the entire T spine in there, all 12 vertebrae. Okay. So lateral to include the costotransverse joints and left and right paranasal line, paraspinal lines. Okay. So technical factors, we want to shoot our C spines, especially our lateral. We want to shoot it a little bit lower KVP, just for the fact that we want a little more contrast. Because looking at spine bodies through the lungs sometimes is difficult. So it's important that we drop our KVP a little bit. It's going to raise our mass, give our patient a little more dose, but our picture is going to be a little bit better. Okay. So down here on the practical, now when we lay our patient down to do the APT spine, you'll note on this left-hand picture from the pectoral muscles down to the neck, there's a slope right there. And that's going to give us fits sometimes as far as differentiation between techniques. It's going to be dark on top and light on the bottom. So we can actually take a bag of fluid and lay it right there above the pectoral and the neck. And that's going to help us see that a little bit better. It's going to make our technique a little bit even through there. And when we do the T-spine, I will show you how to do that in the video. So a low KVP breathing technique can be used for the lateral. So you can actually have the patient breathe normally through the lateral picture. And what that does is if our exposure time is long enough, it's actually going to blur out the lungs a little bit. They're actually really pretty pictures. It's kind of hard to do with our equipment because we can't push our time up too far on them. On this state-of-the-art stuff, you can shoot up to a 3-second, sometimes 4-second exposure time, and it's going to blur out the lungs, and you're going to see beautiful pictures of the thoracic bodies. It's really pretty neat, and you can do that a little bit with our equipment, just not to the extent. Another tip is on your AP, you want the top of your light to be at the jugular notch. That way you ensure that you're going to get the C7 T1 joint space. Okay, it's just good to know. So yes, KVP 66 to 70, 12.5 to 20, depending on the size of the patient. Okay. L-spine, one of my favorite things to do. We're just going to do a simple AP and a lateral on these. 0-degree tube angle. So your central ray is going to enter at the iliac crest. You'll note that the iliac crest is an important part in a lot of our positioning. It's a major landmark as far as X-ray goes. So be aware of where the iliac crest is and how to palpate for that. Okay, because that's where the central ray is on a few of our images that we take. So we lay the patient down on their back, we palpate the iliac crest, and that is going to be where our central ray is going to be. Okay. As far as collimation, we want to include T12 L1. Inferior, we want to include the sacral region. We'd like to include the entire sacrum. We also like to see the SI joints on the AP. Okay. We want to be able to see the transverse processes and the iliac or sacroiliac joints. So on the lateral, we actually want to see the spinous processes, which comes off the back of the spine, and the entire lumbar vertebral bodies. Okay. We're going to shoot these at 70 kVp, the AP between 20 and 30, lateral between 40 and 150. You shoot a lateral, there's more tissue to get through there, so we're going to have to push our mass up in order to get the amount of X-ray photons that we need to expose that. So if you ever have any questions shooting the T-spine or an L-spine and not quite sure where to shoot your lateral at, please give me a call. We'll get you headed in the right direction. So when imaging in the supine position or laying on the table, it's always important to bring their knees up. And if you have a cushion to put under the patient's knees, that's always a good idea. So this helps take out the lumbar lordosis of the spine, because the L spine kind of goes like this. You bring the knees up and it's going to flatten that spine down a little bit and put it a little bit closer to the image receptor, and also open the joint spaces a little bit more. So it's important that you bend the patient's knees up for both the AP and the lateral. Okay, very important. Okay, and these are done at 40 inches. So sacrum and coccyx, you don't do a ton of these, but every once in a while you do. You're going to do an AP, and you're going to do an AP sacrum, an AP coccyx, and a lateral coccyx. Okay, so the central array for the AP sacrum is actually 15 degrees cephalic angle, so towards the head, and for the AP coccyx, it's 10 degrees caudal. So you've got your sacrum that kind of sits like this, right? Okay, and then your coccyx kind of comes along like this. So we're angling 15 degrees to kind of match the angle of the sacrum. Okay, and when we're shooting the coccyx, we're shooting 10 degrees the opposite way to match the angle of the coccyx. Okay, and if you stop and think about it and how the sacrum and the coccyx looks in the body, it makes sense. Okay, but those are two things that you'll need to know: 15 degrees cephalic for the sacrum and 10 degrees caudal for the coccyx. So the central array enters the midpoint between the acis and the pubic symphysis. So we've learned that the acis is the point of the hips. Iliac crest comes down like this into a point, and that's the acis, anterior superior iliac spine, and then comes around like that. So it comes around to the pubic symphysis down here. So a central array is in between the acis and the pubic symphysis. So it's about 2 inches below the acis. Okay, that's where our central array is going to be. As far as shooting the lateral coccyx, you can basically see where the coccyx is. It's right around the curve of the bottom, and if you collimate to that, you're going to get it most every single time. Okay, so collimation wise, of course, we want to get L5S1 because we want to include the entire sacrum, right? We want to include S5. Our articulation of the sacrum and the coccyx will not be demonstrated very, very clearly, given the orientation of the coccyx in this projection. So just my 2 cents worth. An AP coccyx is probably it's a worthless picture because it's so hard to see it. If you have any bowel gas or anything, it's almost impossible, but we still have to take it for the projection. So the lateral, to include the SI joints, okay, pretty self-explanatory. Okay, we're going to shoot those 70 kVp at 10 to 15 mass, depending on the size of the patient. A bigger patient, you're going to double, quadruple your mass. Okay, practical points. Often overlying bowel gas can obscure the bony anatomy of the sacrum, making interpretation difficult, and there's nothing we can do about that. Okay, if there's bowel gas or stool in the way, it's just what it is. We've done our part by taking the pictures. So anyway, sacrum coccyx, we will do a positioning video on this. Hopefully it'll help make a little more sense. Just be aware that it is at 40 inches, and there is a couple different angulations as far as the sacrum and the coccyx go. Okay, SI joints, again, done at 40 inches, 30 degree cephalic angle for the AP at the level of the acis. or between the ASIS and the pubic symphysis. So it's very similar to a sacrum. Okay. For obliques, 0-degree angulation, but we need to oblique our patient 20 to 30 degrees. Okay, and we're always going to shoot the upside. So if we rotate our patient up 30 degrees, we're going to shoot this side. If we rotate them this side, we're going to shoot this side. Okay, the SI joint. Always remember to shoot the upside. Okay, KVP 70 at 18 to 24 mass. Okay, so we want to ensure that there's no rotation. So the mid-sagittal plane and sacrum should be aligned with the symphysis pubis to ensure no rotation. So the middle of the sacrum needs to line up with the pubic symphysis. Okay, perfect. I know I'm kind of busting through these. We just don't do these a lot. Skull projections. We don't do a ton of these either, but it's something that you do need to know for testing purposes. Now, if you can remember 3 different positions as far as skull goes, you can do about mainly any skull work, including sinuses, facial bones, nasal bones. If you learn these 3 projections, you're going to be able to do those. Okay, so the projections we do is a PA Waters, okay, a PA Caldwell, and a lateral. Okay, and these are depicted down here in the picture. So the first one down there is a Waters, and you'll note that the patient's chin and nose are against the image receptor. And the way I remember Waters is the patient is trying to keep their head up out of water. So their chin and their nose are against the image receptor. Okay, so central ray for the Waters, the central ray is actually going to exit the nasion. Okay, or the upper lip. This is your nasion. Okay, and this is your acanthon. Those are 2 landmarks that you need to know. Okay, so it's not where the central ray goes in with skull work, it's where it exits. So we're going to angle our tube 15 degrees caudal, so 15 degrees down. It's going to hit the back of the head, and it's actually going to go through the head and exit the upper lip. Okay, so if that line exits your nasion or your upper lip, you are in good shape. Okay, you just need to collimate to include the skull. Okay, now with skull work, it's all about collimation. You're going to pretty much use these same positioning things, but you're collimating to the part that you're looking at. So of course, for the skull, we're going to include the entire skull. Make sure that we have collimation light on the laterals and superior and at the occipital. Okay, so yeah, the Caldwell is 15 degrees caudal, and it's actually gonna, sorry, I lied to you. So yeah, it's gonna exit the nasion right there. So for the lateral, you're gonna oblique your patient in there, have them turn their head so their head is parallel with the image receptor. We want to include the entire skull. Central ray is going to go about 1 inch above the EAM or the external auditory meatus or the ear hole. Okay. Technical factors, KBP 70, mass 12 to 20. Okay. So practical points. It's very important that we use markers on our skull work. Okay. Where we're shooting our images PA, it's very difficult to tell which side is which if you do not use a marker. Okay, so make sure that you're using a marker, whether it be right or left, on the right or left of the patient. That way, there's no confusion on what side is what when you're shooting skulls. Okay, very important because we want to remove earrings, glasses, hair clips, hearing aids, dentures to avoid any artifacts when we're looking at skulls. So let's just run through the positions real quick. The AP or the PA Waters, patient's chin and nose are against the image receptor, and it is a straight shot. Okay, exiting the nasion. Okay. Now the PA Caldwell, it's the opposite. The forehead and nose are against the image receptor. you're actually angling caudal or down 15 degrees, right? And your central ray is going to exit between the eyes. Okay. And then we've got our lateral just an inch above EAM, collimating to the sides of the head, the way they've done that there. Okay. Yeah, people get scared about school stuff, but if you boil it down to its simple essence, it's not that bad. Once you learn these positions, they're actually kind of fun to do. So, but just remember to always use your markers, okay, on schoolwork. So you always are very sure as to right and left. Nasal bones, we do those very seldom, but they're kind of fun to do. We're just going to do a PA waters. Okay, same thing. Patient's head out of the water, right? And the nose against there. We're going to collimate down a little bit to the nasal passages. Okay, and then we're going to do 2 laterals. We're going to do a right lateral, and then we're going to flip their head and do a left lateral. And we're going to collimate to see. I like to call it the nasal carrot. It looks like a carrot. And that's the bone that they're looking at. Okay. So collimation within 2 inches of the nasal bones on all sides. Pretty easy. So you're collimated pretty tight. Oh yeah, you can see the carrot down there on the bottom right. And that's kind of what a nasal fracture looks like right there. Again, make sure you're using your markers on these. Remove glasses, nose piercings to avoid any type of artifact. Collimation is key to nasal bones. We're looking for a very small bone, so contrast is very important. And the more you collimate, the more contrast you're going to have. Okay, we're going to shoot these at 70 kVp. You can actually bring that down a little bit if you'd like to. Mass is between 10 and 18. So our laterals, we're going to shoot those kind of like a finger technique. You look at that little nasal bone, it's pretty tiny, right? So we're going to shoot those at 55 at 3.2. It's basically the same technique as a finger. Okay, that's what you're going to shoot both of your nasal laterals. Okay. Let's see, ribs. We need to go through ribs real quick. We do a lot of ribs. So projection, it all depends on the patient. We're either going to do an AP or a PA. It depends on where the patient is hurting. If they're hurting up front, we're going to do a PA because we want the injured area to be against the image receptor. Okay. If they're shooting in their if they're hurting in their posterior ribs, we're going to do an AP and put their back against the image receptor. Okay. So it's all dependent on where the patient hurts as to whether you're going to shoot an AP or a PA. Okay. It depends on the region of interest of the injury. We're going to do an oblique, whether that be PA or AP, and then we're going to shoot some lower ribs. It's really hard to get the entire set of ribs on one picture unless the patient is small. So on your first picture, your AP or your PA, always make sure that you've got your top rib. Okay, so always have a little bit of collimator light at the top of the chest cavity, right? We want to collimate to that side of the ribs. We want just the other side of the sternum. We want the lateral skin margin. We want to see the top rib and as far down as we can get. Okay. Technical factors, I shoot these, between 65 and 66 kVp, just because I want more contrast to see those ribs. And just know that if you're shooting in an 80-year-old ribs, it's just not going to turn out good, no matter how hard you try. Dense bone, you get the best ribs. So young kids, skinny kids, you're going to get great ribs. Older people, obese people, it's a little bit harder to get contrast. But if by lowering your KVP and shooting it at 65, 66, it's going to help you out as far as getting a good contrast on your ribs. Okay. So collimation, we already talked about that. We want to make sure we get past, include the sternoclavicular joint. And with your lower ribs, you want to make sure that you get the diaphragm in the costophonic angle, or you want to see the bottom ribs, basically. Okay. Let's see. Always make sure that the area of injury is marked with a BB. all the clinics should have a packet of BBs with a roll of tape. And a lot of you have asked me, what on earth is that for? That is for ribs. The patient is going to show you the region where they're hurting. You're going to tape a BB to that region. It just helps the radiologist know where they're hurting. It helps them diagnose rib fractures a little bit easy, so they're not searching everybody. They have an area of interest, but that's the reason we use BB. Okay. Let's see. Like I say, the area of pain is placed closest to the image receptor. If the full rib cage is not visualized on the AP and PA, a lower rib image must be taken. Okay. One fact that if you're shooting a PA oblique ribs, you're actually going to shoot the side furthest away from the image receptor. I know it's just opposite of what we teach. If we're shooting AP and the patient's back is against the image receptor, we're shooting the oblique that's closest to the image receptor. Okay, now if we're PA and we've got them oblique, we're shooting the oblique that's furthest away from the image receptor. And the reason we do that is to elongate the ribs a little bit so we can see the axillary ribs a little bit better. And this will make much more sense with our positioning video. I know it's kind of hard to look at that, and it is kind of confusing. But yes, there are certain ways you do need to do ribs, and we will talk about that more with our positioning video about ribs, which will come out here in a little bit. And I put up here that it's everybody's favorite. I get the same complaint from everybody when it comes to ribs, because they're a little bit tricky to get sometimes. Okay. Special views, we're almost done here. Decubitus, we don't do a lot of this, just for the fact that we're really not set up to do this. Decubitus x-rays usually are done on a stretcher. It's where you place the patient on their side and their back or front against the image receptor, and you actually shoot through the front of the body or the back of the body, kind of like the picture down here on the left. This picture on the right is actually a really neat picture, and this is a decubitus picture. This is a post-barium swallow, it looks like. But you can see the level of the barium, how it's kind of laying on its side. And that's the reason they do decubitus x-rays. If the person cannot stand, we'll lay them up on their side and take the picture so we can see air fluid levels. Okay, just remember what a decubitus is. It's the patient laying on their side and we're shooting. Okay, lordotic view, we do very, very, very little of these unless you're doing a clavicle and don't want to angle your tube. But the lordotic view is having the patient step a foot away from the image receptor and leaning back so their shoulders are against there. And that's the lordotic view. Okay. In the case of a clavicle, it's going to place the clavicle above the shoulder girdle. Okay. And we do these for some chest x-rays for a special view, which you can see there. It allows us to look at the apices a little bit. So, just be familiar with the decubitus and a lordotic view. Okay, know what those are. Okay, well, I appreciate you guys coming by today. I know that's kind of boring to go through it that way, but when the positioning videos come out, it's going to make much, much more sense. I'm excited for this new program. I hope you guys will jump in and learn the stuff and use me for any questions that you have, and get to the point where you can take and pass that test. I know that you guys can do it. Like I say, I look at a lot of x-rays every day, and the pictures that I'm seeing are much, much better. And I appreciate everybody's hard work as far as that goes. Thank you so much. And I appreciate you guys being here. You guys have a great weekend, and we will see you next week. Okay, see you guys.
See you, Eric.
See you, Joel.